as you've kindly introduced me, it's Khalid Ali. I'm a reader in geriatrics, a clinical academic at the medical school, and I'm just going to share with you an overview on vascular dementia. So I'll be talking about definition, terminology, epidemiology, some diagnostic criteria, a brief comment on prevalence, clinical presentation. I will talk a bit about underlying pathogenesis and leading to how to prevent and treat. We must consider modifiable and unmodifiable risk factors. So these are my disclaimers. I've received funding from Pfizer company in relation to a topic related to anticoagulation decisions in older people with multimorbidity, frailty, and dementia. I'm a NICE committee member in the Rehabilitation After Stroke Guidelines, and I'm also a director at Brighton and Hove Health Watch team. It's a volunteer role, but we do consult with service users, older people living with dementia and their families about health and social care services. So, starting with definition, vascular dementia is a neurocognitive disorder that represents clinically significant cognitive impairment. The key thing is that it is directly related to vascular injury to the brain associated with several possible contributory factors. And here I'm talking about cardiovascular risk factors. So this cognitive impairment, as you can imagine, that the impairment is related to which part or domain, cerebral domain, is affected by a vascular injury or a vascular insult. So if it's a speech area that's affected predominantly following a cerebrovascular event, being that ischemia, large vessel ischemia, small vessel disease, or hemorrhage, the part of the brain that is affected, for example, that affects speech, then the cognitive impairments related to speech will be the prominent feature here. So, and as it's vascular, so the presenting symptoms are related, or the symptoms at presentation are related to which vascular territory is involved, a large vessel disease or small vessel disease. So, as you imagine, this will be, vascular dementia is broadly understood as a decline in memory and impairment in two other intellectual domains. The resulting impact of that is interference with activities of daily living in an individual. With the vascular origin as vascular dementia, there must be clinical signs of stroke, supporting history from taking history from a past history of a stroke or a transient ischemic attack, and examination findings, clinical examination, the presence of risk factors for stroke, and Professor Rajkumar has covered some of those, particularly with reference to hypertension, but we will be covering diabetes, hypertension, and other risk factors. Along with neuroimaging evidence, so we'll talk about the different criteria and different modalities of presentation, but radiological imaging, neuroimaging support, and symptoms of cognitive impairment and resultant impact on ability to perform activities of daily living. And that is within a time frame of 3 to 6 months from onset of the stroke, from the vascular event. So we can't diagnose it straight away. We have to wait 3 up to 6 months to make a formal diagnosis, history, clinical examination, neurological findings, imaging, neuroimaging, as well as impact on cognitive function and activities of daily living. 6 months from onset of a vascular event or stroke. In the absence of a history, because a lot of stroke presentations can be can go unnoticed, either by patients themselves if they're subtle, unnoticed by patients, family members, and they have not been brought to the attention of clinicians. So in the absence of a history of stroke, there should be some findings at presentation. And we said this presentation up to 6 months after onset of a stroke or a vascular event, cerebrovascular event. So at the time of making the diagnosis, if there's no history, there must be some neurological signs to substantiate or to support a cerebrovascular mechanism. So being labeled as vascular dementia or dementia of vascular origin, as you can imagine, that can cover a whole wide of areas in the brain affected. So it can be small vessel disease of subcortical, variation. It could be multi-infarct, several infarcts in different parts of the brain, or infarcts or vascular injury being infarct, ischemia, or hemorrhage in a strategic cerebral domain as the thalamus, caudate nuclei, hippocampus, or the internal capsule. Hypoperfusion is another vascular insult or injury in specific cerebral locations, watershed infarcts, for example. We know that mixed dementia, mixed vascular and Alzheimer's dementia is a very common clinical presentation. And in those, we will find vascular injury as well as Alzheimer's disease or dementia of Lewy body manifestations on neuroradiological imaging. Hemorrhagic strokes, again, is a variant. Hereditary vascular dementias, where there are different, definite or identified genetic mutations, such as CADASIL and CARASIL disease. So this can all be referred to, the terminology or the labels change between different organization and different settings. What we're talking about here, vascular dementia, can also be labeled as vascular cognitive impairment, or if there's a definite evidence of past history of stroke, post-stroke dementia. So it can be labeled differently, but the underlying unifying factor is that cognitive decline, cognitive impairment, diagnosis of dementia with vascular element to it, either ischemia, hemorrhage, or small vessel disease. So maybe I'll just talk a bit about how does the large vessel and small vessel disease result ultimately in cognitive impairment or cognitive decline. We talk about modifiable risk factors, diabetes, hypertension, cholesterol levels, as well as lifestyle factors, diet, exercise, physical activity, sedentary lifestyle, and so forth, as well as non-modifiable risk factors, genetic variants, age, and race. All of the above resulting or culminating in large and small vessel disease lead to either small vessel disease manifesting as small or white matter changes, small lacunar infarcts with microinfarcts or microbleeds, or large vessel disease presenting as macroinfarcts in neuroimaging. What this ultimately leads to: brain volume loss, atrophic brain, resulting in cognitive impairment. So it is important to appreciate the limitation of these definitions, these labels, because of the overlap of various types of dementias. And we know that mixed type dementia, which includes features of vascular as well as Alzheimer's disease, are quite common. So presenting this, and even the spectrum of manifestation of clinical presentation, is heterogeneous, is varied, time of onset. So it's difficult to define vascular dementia as a one disease entity. More appropriately, it should be labeled as a spectrum from mild cognitive impairment to with an underlying vascular pathology till advanced manifestations of cognitive decline. It might be argued that this classification or categorization is academic in nature, and the definitive diagnosis is actually, if we're saying vascular dementia, we need a neuropathological autopsy or post-mortem or autopsy findings to substantiate the vascular mechanism as the primary or the predominant reason or cause for cognitive decline, to differentiate this from neurodegenerative aspects or components to dementia. So, having shared with you the limitations of the definitions that we have in relation to vascular dementia because of the complexity and of different and the heterogeneity of vascular brain injuries and its overlap with Alzheimer's disease, these limitations actually even translate into the epidemiology and the diagnostic criteria. But what we do know using these definitions, that vascular dementia is the second most common cause of age-related dementia after Alzheimer's disease. Some studies suggest that it accounts for 20% of all dementias, that is vascular dementias. So summarizing again the criteria supporting predominantly vascular component to dementia presentations, it's a clinical presentation of stroke followed in the next subsequent 3 to 6 months by cognitive manifestations, neuroimaging support of vascular injury or vascular insult, that being macro large vessel disease, lacunar or microinfarcts, characteristic cognitive impairments that are elicited or identified from history and cognitive assessment tools, stroke manifestations, residual motor or sensory weakness or speech, visual or balance problems, the presence of risk factors for stroke, and a clinical course that is compatible with maximum deficit at the time of a stroke, followed by improvement. And when I say improvement here, improvement in the motor as well as the cognitive impairments over time, but over the course of years, there's that progressive decline. And some familial factors, history of vascular pathology that runs in families. So now we know, particularly in relation to Alzheimer's disease, there are new biomarkers, innovative CSF results, genetic studies, and advances in neuroimaging and cerebral positron emission tomography, PET scans. All these modalities fine-tune or improve the diagnostic criteria of differentiating between the vascular dementia, mixed types, and Alzheimer's disease. And there is a role for these new modalities of investigation or diagnostic criteria in making a diagnosis of vascular dementia. And we'll talk about this later when we talk about pathogenesis. So what are these vascular dementia spectrum? As I said, it was previously referred to as multi-infarct dementia in view of the cumulative cerebral tissue loss related to not one, but a series of or recurrent ischemic strokes as the primary mechanisms. But we're not talking here about ischemic strokes. When our understanding of vascular component, hemorrhagic stroke is also contributory to vascular dementia. What we do know from studies, surveys, that based on pathological findings, it is thought that 50 to 100 mil of brain tissue loss will translate into clinical manifestations of cognitive decline, or dementia. I will move to the next one. So how do we as clinicians assess that cognitive decline? Several tests. I'm not an all-day psychiatrist. I'm a geriatrician, a clinical geriatrician. So we use simple, easy, reliable bedside tests. The one that is mostly advocated or used for bedside assessment, initial screening bedside assessment for cognitive decline, is the MOCA test, the Montreal Cognitive Assessment Tool. It's been reported to be superior to the MMSE, the Mini-Mental State Examination, for the determination of vascular dementia, and is particularly reliable. That is because of the fact that the MOCA has more emphasis and provides more information on attention and executive function impairments in vascular dementia, in presentations of vascular dementia. So the main take-home message from this is, if you want to assess, use a tool that is more reliable, that is more diagnostic, and that is the MOCA test. Okay, so as I've explained the limitations and the challenges of the diagnostic criteria applied to vascular dementia, that translates into limitations in terms of quantifying the magnitude of vascular dementia as a distinct entity. The global frequency of autopsy-verified vascular dementia has been estimated between 10 to 15%, but again, highlighting that there is considerable variation in the reporting of vascular dementia statistics. What we do know, however, is men tend to be affected more frequently than women, presumably related to their overall higher risk factor for vascular insults, primarily stroke. The pathogenesis, which is important to understand in relation to vascular dementia, while it's heterogeneous, but it provides important therapeutic targets. And these therapeutic targets are important for prevention, for primary as well as for secondary prevention. What we do know when we compare vascular dementia in comparison with Alzheimer's disease, we know that there is expected decline in cognitive function. We know that initially after a stroke, the cognitive impairment should stabilize and improve. But common features of vascular dementia in the long-term or chronic phase are these three specific features: apathy, lack of interest, depression, and post-stroke epilepsy. So coming back to the pathogenesis, when we know, while knowing that it is a vascular insult or injury, this could be a thrombus or ischemia, in situ thrombosis related to atherosclerosis, fibrinoid necrosis, or lipohyaluronosis, which can overlap again with some of the mechanisms related to hypertensive intracerebral hemorrhage or bleeds. Other vascular, primarily vascular pathology, such as inflammatory conditions, vasculitis, tear in the intimal or the endothelium in vascular territory, vascular dissection, aneurysmal dilatation, or AV malformation, anatomical malformations, arteriovenous malformations, can also be found. That's all as part and parcel of the vascular component, underlying components of vascular dementia. What do we expect to find? A whole variety of ischemic insults, from small cerebral microinfarcts to radiologically evident lacunar infarcts, to small vessel disease presenting as white matter hyperintensities to bleeding radiological manifestation, cerebral small microbleeds or lobar hypertensive bleeds, followed by resorption and resolution of those bleeds and residual evidence of previous bleeds, cortical superficial siderosis. So hemosiderin deposition of the denatured or the blood component. And sometimes this all results in scarring, and actually this is quite a common manifestations, scarring and brain volume loss. So we can see that there are visible vascular spaces in the MRI. Again, this is just to share with you the underlying being a primarily vascular pathology origin, being that bleeding or ischemia or blood clots, there is blood supply problems, hyperperfusion of specific brain areas. How is that followed through? Inflammatory processes, hypoxic sequelae, release of reactive oxygen species, the inflammatory and the inflammatory processes of interleukin-6 and tumor necrosis factor alpha, the apoptosis and the cerebral neuronal brain loss, the oxidative stress is again a spectrum or a result and a factor that perpetuates the vascular damage in terms of endothelial dysfunction, further neuronal cell loss, with ultimate manifestation as vascular cognitive impairment / vascular dementia. So the underlying processes are blood volume hyperperfusion resulting in inflammation, hypoxia, and release of perpetuating factors such as the reactive oxygen species and oxidative stress. Moving on, I would like to talk a bit about small vessel disease that is quite common in vascular dementia presentations. 25% of ischemic stroke presentations are associated with small vessel disease. This is a neuroradiological findings on MRI brain scans where we do find white matter hyperintensities, lacunar infarcts, as well as cerebral microbleeds. And there is established evidence of the correlation between white matter hyperintensities and progressive cognitive decline. I won't mention a lot about genetic factors, but there are several. While talking about all the complexity and the challenges of diagnostic criteria and in vascular dementia, we should not dismiss or ignore established underlying or secondary risk factors for cognitive impairment. Hypoactive thyroid, underactive thyroid, thyroid function, metabolic profile disorders, vitamin B and 12 deficiencies, as well as screening for other connective tissue disorders that might be associated with cerebral vasculitis, neurosyphilis, HIV-related disease, neurosarcoidosis, as well as the overlap or the presence of mixed type dementia, vascular / Alzheimer's disease manifestations. So keeping an open mind about the other common and maybe less common like neurosarcoid manifestation resulting in dementia or cognitive decline. Okay. I won't mention a lot about hypertension because that is covered by Professor Raj Kumar, but I will mention just a few things about lifestyle factors and vascular dementia. There is evidence to support active physical and mental exercise to prevent or delay progression of cognitive decline in vascular dementia. Diet designed to reduce oxidative stress, such as the Mediterranean diet, has promising evidence that it also helps in protecting cognitive capacity. Probably, generally speaking, the widespread or common knowledge, whatever is good for your heart is good for your brain. So that's being exercise, proper diet, as well as good control, optimal control of diabetes, hypertension, other vascular risk factors like atrial fibrillation, as well as cholesterol management. Coming towards the end, what about anti-dementia medications? Cholinesterase inhibitors are usually used rather commonly for Alzheimer's disease, particularly in the earlier stages of Alzheimer's disease. But they're not uncommonly used in vascular dementia, but with little evidence or less evidence to support their use. They're helpful when it's mixed vascular Alzheimer's disease dementia. But one meta-analysis suggested that anticholinesterase inhibitors provide protection against further decline, with some studies reporting benefit for both donepezil, Aricept, and galantamine in vascular dementia and mixed dementia etiology. What about herbal remedies? There is, again, some reviews and a systematic review suggesting that they might have evidence, but there is it's limited evidence, preliminary evidence, and they need to be evaluated further. Other factors which are modifiable: body mass index, plasma triglyceride, high density lipoprotein, cholesterol LDL, low density lipoprotein, total cholesterol concentrations, non-alcoholic fatty liver disease, smoking, and even gut microbiome or the gut microbiota are all considered as risk factors for vascular dementia in view of the atherosclerosis pathway or link to brain injury, vascular brain injury, and cognitive decline. So, in summary, what I've hoped that I've shared with you, that vascular mechanisms and vascular dementia is the second most common cause of dementia presentations. The vascular mechanism, the pathogenesis, is well defined and understood. It contributes to the vascular decline, despite the fact that there are heterogeneous presentation related to vascular distribution and the underlying spectrum of vascular, ischemic, hemorrhagic, as well as small vessel disease, and the overlap of small vessel disease with other types of dementia and particular neurodegenerative disorders. It is still highly important and crucial to identify a vascular component, because they preceding, especially in primary prevention, preceding the actual onset of vascular dementia, that attention to vascular pathology may allow initiation of interventions that control, such as controlling high blood pressure, diabetes, cholesterol, lifestyle interventions, as well as the herbal remedies and some smoking cessation programs, dietary interventions. They all have the potential for halting or delaying progression. And this is key, as I mentioned, in primary and secondary prevention of stroke. So thank you very much for your joining me on this webinar in this conference. I'm pleased to be part of it. I have provided lots of references, and I'm happy to share my slides and my references with the audience. And this is my address for correspondence. Thank you very much.